Thank you so much for that kind introduction. It's really happy to be here. So my goal today is to discuss how do we enter into management of obesity from a practical perspective. How do we actually enter into that space? So I want to start with this quote. If an egg is broken by an outside force, life ends. If broken by an inside force, life begins. Great things always begin from inside. When we are going to discuss about behavioral changes, it's very important to keep in mind that change comes from inside. These are my disclosures. And today our conversation is going to be focused on how to discuss obesity is a chronic heterogeneous disease and to evaluate practical approaches to comprehensive obesity management and to discuss motivational interviewing in obesity management. Meet Thomas. He's a 16-year-old boy. He dreams of becoming a professional football player. He struggled with severe obesity since age 8. His eating phenotype, he has a robust appetite with night eating and he grazes on snacks. He gets headaches 3 to 4 times per week. He has hypertension. He uses CPAP for sleep apnea. He has a hemoglobin A1C of 5.1%. He has tried different diets. Now he's on low-carb diet. He's already following lifestyle changes and has had a lot of failed attempts at change. How can we help Thomas? Thomas's story is not unique. He is one of the 5 children and adolescents in US who is obese. And as I said before, obesity is a chronic, relapsing, multifactorial neurobehavioral disease. It's a gateway disease. It causes more than 200 medical conditions. In Thomas's case, he already has hypertension. He has sleep apnea, and it has significantly impacted his quality of life. And obesity management is not about the size of the body. It is about decreasing the disease burden over time. So how do we choose medication for Thomas? Thomas is interested in only one medication. He wants monotherapy. He does not want injections. Considering the fact that he gets headache and he eats nighttime and grazes all the time, I decided to use topiramate for him. It has an efficacy of 5 to 10% weight loss, as you can see from his growth chart, in conjunction with continued lifestyle changes. Let's say, what if we do not consider obesity as a disease? What will happen? The unethical view is that this is a decision from the patient. They are failing somehow. That leads to social stigmatization, patient blame, and suffering. And again, that will lead to increased medical complications, increased cost, healthcare utilization. In reality, it is not the patient's fault. And also, we need to think about the implicit bias these patients have to endure. They have to do these medications if they don't have a strong willpower. So that's another aspect they have to think about. So comprehensive obesity management can be divided into 3 components. One is intensive health behavior lifestyle treatment, IHBLT. That's the backbone of treatment. And my next speakers will be touching upon the diet aspect on it. And then pharmacotherapy, we need to make sure and recognize one size does not fit all. We need to consider risk benefits. And the third component is bariatric surgery. And again, my co-speakers will be talking about bariatric surgery. And all these 3 modules are continuum of care rather than a staged approach. So now, how do we implement all these 3 modules? We have to implement it by empathetic, non-stigmatizing care, use people-friendly language with empathy, sensitivity, and support. And we do that through motivational interviewing. and it's a patient-centered approach focusing on medical risks and overall health. So the biggest question is, how do we determine which treatment is required? And for that, we need to really know how much weight loss is necessary to improve specific metabolic issues. So here you can see, for improvement of type 2 diabetes, type 2 remission, hypertension and cardiovascular risk reduction, at least 10 to 15% weight loss is needed. And some conditions like biomechanical function improvement, it is different. So we do need to know what are the comorbidities our patients are going through so we can assess and determine how much weight loss is needed. And when we look at this figure, it talks about how much weight loss we can anticipate with some of the treatment. So in the case of diet and lifestyle treatment alone, anywhere from 5 to 9% weight loss is possible, and it has to be provided longitudinally. And unfortunately, in the interest of time, I wouldn't have time to talk about that. And when we combine diet and lifestyle with medications such as phentermine, phentermine topiramate, naltrexone, bupropion, or Listat, we can get up to 10% weight loss. And when we are thinking about GLP-1s, we get more than 10% weight loss. When we go to GLP-1 agonists such as semaglutide, we get up to 15% weight loss. Again, when we think about tirzepatide, GLP-GIP agonist, we might get 15 to 20% weight loss. And with bariatric surgery, we get larger amount of percent weight loss. So we all know stories about celebrities who take weight loss medications from social media, and we are all well familiar with the Ozempic phase. So when we think about pharmacotherapy, how do we choose a medication for the patient? We need to assess the phenotype of the obesity, and we have to target their underlying biology. And this has to be in conjunction with intensive health behavior lifestyle treatment. So insulin resistance prediabetes, GLP-1 receptor agonist, dual GIP, GLP-1 receptor agonist are helpful. Hungry gut, strong hunger, poor satiety, food craving, GLP-1 receptor agonist, dual GIP, GLP-1 receptor agonist are helpful. In the case of patients with depression, anxiety, eating in response to emotions, bupropion or naltrexone are efficient. Binge eating and emotional eating, lisdexamfetamine and topiramate are helpful. Hungry brain, phentermine, topiramate, lisdexamfetamine are helpful. Slow burn, lack of energy, phentermine, lisdexamfetamine are useful. So let's delve into case 2. This is a 12-year-old girl. She has had severe obesity since age 6. Her eating phenotype, she has significant nighttime eating and lack of satiety. She also complains of daytime fatigue. She participates in physical education and after-school sports. She is ashamed of her acanthosis, which you can see she even has verrucous acanthosis. And she has a screen time of more than 3 hours. Her A1C is 5.5%. She has been attending the weight management clinic for 2 years with intensive health behavior lifestyle treatment. So when choosing the medication for this patient, she does not want injections, but she wants the most effective oral option. Her obesity phenotype, given that she has fatigue, topiramate alone was not a choice for me, and I considered her nighttime eating behavior. So for her, I considered phentermine topiramate extended release form slowly titrated to the current dose, which has an efficiency of 10% weight loss, as you can see from her chart. And this is in conjunction with lifestyle changes. And now we'll move on to case 3, which is a 17-year-old girl. She has severe obesity since age 10. She plays softball. Her eating phenotype, she has strong hunger, lack of satiety, strong family history of obesity and type 2 diabetes. this is not uncommon. Majority of our patients with obesity have family history of obesity. And she has polycystic ovary syndrome with irregular cycle, hirsutism. She has experienced bullying. She uses CPAP for sleep apnea. Her hemoglobin A1C is increased at 6.7% in the type 2 diabetes range. She has an elevated ALT of 75. Her triglyceride is elevated at 420. She has an elevated testosterone for a female. And she has been working on addressing her body weight for a long time. So in choosing the medication, she does not want daily pills. She has type 2 diabetes, sleep apnea, MAFLD, PCOS, dyslipidemia, which means she needs at least 10 to 15% weight loss for metabolic health. So in her case, she got approved for semaglutide because of her type 2 diabetes indication. And it was titrated to her current dose, and it was effective in reducing her weight to more than 15%. And we continued her intensive health behavior lifestyle treatment. So what we need to know is we have a growing toolbox of medications. Once we decide to prescribe a medication, we need to know the full adverse effects. And we have to also think about, does the benefits outweigh the risk of disease burden of obesity? And we need to also remember, obesity is heterogeneous. Same medicine may not work for everyone. And the same dose may not work for everyone. So we have to reassess the patient and decide, do we need to adjust the dose? Do we need to change the medication? What is our strategy? And now I will address my second objective. How do we provide empathetic, non-stigmatizing care? I will try to enter into that through motivational interviewing. When I think about motivational interviewing, I want to share a story with you. It was going to be one of the regular clinic days, full of patients. And the next patient I was going to see was a 14-year-old who was almost 400 pounds. As I entered into the room, I greeted both mother and the patient, and I started explaining my usual way how to reduce some weight. And the mother stopped me. She said she does not want to talk about weight. I was taken aback. I had so much to offer to them. She said she only wanted to hear about fatty liver disease, hypertension, and type 2 diabetes without discussing the body weight. At that moment, I realized what I needed to do was to establish a human-to-human connection. And I did. So this made me delve into motivational interviewing. And our old way is, tell me what's wrong, I'll tell you how to fix it. We doctors have a writing reflex. So usually I used to give 2 to 3 reasons on why to lose weight, then exaggerate the importance, then instruct a few ways to get started today, how to do the right thing, assure them how great they will be if they do it today. And if you meet with any doubt, give extra reasons, try to convince. And it doesn't work. When we deal with behavioral changes, even though we are coming from a good place, good heart, this doesn't work. This will sound like judgment. So these are the 4 processes of motivational interviewing. One is engaging. We have to create that calm, non-judgmental relationship. And then focusing, we need to assess what is their goal. Clarify with the person what is their focus. Then we need to evoke, understand the whys. They have a reason. What do you think will work for you if you continue? What's your focus? Why were your previous attempts not successful? And then we need to plan. Here we are gently guiding on what to work on. The patient has the knowledge of how to reach there. Our role as a healthcare provider is to gently guide them. That is our role. So basic skills of motivational interviewing. We start first with asking permission. Would it be okay to discuss? your weight today. And then there is an acronym OARS or OARS. The first one, O, stands for open-ended question. This is to understand more about the patient. Once we know their journey, we use affirmations. We tell them about their strength. It's about you. You are resilient. You are honest. And then we need to do reflections. Reflections are summarizing or paraphrasing what we listened from them, what we heard. So the patient feels like they're being heard. And then we give summaries. There are takeaways as to what we really learned today. And so this is what we are going to do. And we achieve that through elicit, ask them what to do, then provide some information, and then elicit again, and then provide. Providing could be statistics, our knowledge, options. So in a way, this is like most of our conversations are like on the left side, we have some weeds, some flowers. As the physician doing MI, we organize that, present them with their strengths, demonstrate active listening, guide them, clarifies the complex information, and provide them with a summary that ties everything together, and provide them with a bouquet of flowers that clarifies everything, organized beautifully back. So this is what is, in summary, motivational interviewing. So my takeaways are, consider our goals. What outcome do we want to improve? Do we want to achieve short-term outcome improvements such as hypertension, A1C, or do we want to achieve long-term outcomes like improved cardiovascular health, cardiovascular morbidity reduction? And we need to also consider, depending on that, what % weight loss is desired. Do we want weight stabilization, weight maintenance, or weight loss? And choice of pharmacotherapy depends on the phenotype of obesity, phenotype of eating, underlying biology. Is it insulin resistance? And it has to be through a shared decision model. We have to consider practicality and patient preference. And in reality, motivational interviewing can reduce the provider burnout and increase confidence for the patients. And thank you so much for listening. I'm really excited to take any questions.
Thank you very much for inviting me. And thank you very much for the nice introduction. So today my topic is a little different from others. So it's more research-based. My research program actually focuses on how genetics affect how people metabolize nutrients. So since this is a topic which many physicians may be aware of or not, I don't know, but so I included some slides for as a primer for genetics, and then we move on to nutritional genomics and precision nutrition. So to start with, I will talk about some primer on genetics, and then I'll move to nutritional genomics, and then talk about precision nutrition, how they all apply to obesity. So everyone, I'm sure you're aware of DNA and RNA. So I'll quickly walk through this. And we know that DNA is made of double helix, and two strands, and one strand comes from each parent. And they are basically, these are nucleotides. Can you see my arrow mark?
Yes, you can see. Yeah.
Okay, thank you. So these are the nucleotides, adenine, thymine, guanine, and cytosine, and they form a backbone on a sugar phosphate bone. So how are all these are like your coding or whatever the behind the scenes factors. They actually create a code, and then this is what is transcribed. So basically, this double helix structure is the one which contains this code. Various combinations of those nucleotides actually enter and become the RNA. And in DNA, we also have exons and introns. Introns are taken out, exons are moved to RNA, which is also called gene expression. And then we move on to, they get translated to protein, which can be an enzyme, which can be a protein hormone, or some cell building block. So that is how it gets transferred. So any change in these nucleotides can affect how the amino acid is formed, which goes on to form a protein. So if you have a UUU, which is a RNA has a uracil instead of thymine. So if UUU gets converted to C, the amino acid won't change, it'll stay phenylalanine. But if C gets converted to A, then the amino acid will change into leucine. This small, it may look like, but they can make a lot of difference in how proteins are formed. So the most widely studied mutations or polymorphisms are single nucleotide polymorphism. There are many other types of structural variants, but I'm not going to talk about them. We'll just focus on SNPs. So they are called SNPs. So if this is like a sequence on a genome, gene and whole genome actually, and one nucleotide C gets changed to G, it is called a single nucleotide polymorphism. There are 10 million, more than 10 million SNPs, and a lot of them we don't even know what their role is. So these SNPs, how do they affect us? They can be a nonsense SNP. What does that mean? That they stop the amino acid being formed and there is no protein formed. Their frequency is very low in populations and genome, but their relative risk is pretty high. Similarly, non-synonymous, what it does is it changes the amino acid. It has an amino acid, but it changes it completely. And then this frequency is also very low, and the relative risk for it can be a disease, it can be like blood pressure high or anything, can be pretty high. Synonymous does not change the amino acid, but can still have risk. It can still confer some risk. Genes, SNPs in promoter regions, like in genes, there are some regions which are promoter regions, which can influence how gene is expressed. So that is where, so they also low to medium, but the relative risk is somewhere low to high. Intronic SNPs, which get spliced out when it becomes RNA, also can affect how RNA is formed. Previously, we thought intron doesn't have any function, but now we know it's not so. So let's take an example. I just took an example of a cholesterol. A person with the lowest one, AJ T in this location and C in this location, may have only 105 milligram per deciliter cholesterol, whereas the uppermost, a person just a change of G from T can actually have a 180. So you see how a one nucleotide can change make such a can make such a difference in cholesterol levels. So we know that genes don't live in isolation. They don't, we just said that they are actually the bullet, but trigger is the environment. So without a proper environment, genes cannot act. Genes makes a person susceptible, but unless the right environment is provided, basically it will not affect them. So this is what we call a gene environment interaction. The effect of a particular genotype. Genotype means one nucleotide coming from one parent and one nucleotide coming from other parent. So genotype is always a combination of two nucleotides, which we also call alleles. So let's say the effect of a particular genotype differs in different environments. This is a classic case of twins. They were reared apart and they found that some of the phenotypes were same, but some of the phenotypes were totally different. Or two people with different genotypes, different ethnic groups, or different genotypes growing up in the same environment can still show a different phenotype. So in what is nutrigenomics? What is nutrigenomics is actually the same gene environment interaction, but in the environment case, there can be several types of environment. We are going to, in this case, nutritional status or nutrient metabolism is our actually environment. So that is what we are talking about here, nutritional genomics. Some people also call nutrigenomics. It's basically interplay between nutrition and human genome. So it contains one, it is nutrigenetics, which is study of individual genetic differences influencing metabolism or diet response and susceptibility to diseases. Basically, what it means that what a person is eating, how their genes metabolize them. So internally, what genetic makeup you have, how they influence the metabolism. The other side is nutrigenomics, which is like what I am eating or what a person is eating, how that affects how a gene is expressed, how the protein is formed, how a metabolomic response at the molecular level. So these two together form something called nutritional genomics. So let me give you some examples. Phenylketonuria. This we now nutrigenomics, some fancy terms have come through late 90s, but phenylketonuria, we have known this since 1930s, and it's a classic case of nutrigenetics. It's basically phenylalanine is an amino acid essential, gets converted to tyrosine, and which goes on to help with formation of dopamine. So, and this is the enzyme, phenylalanine hydroxylase. If this enzyme, no mutation, no SNP, everything works perfectly. But if this enzyme has a SNP, phenylalanine can no longer be converted to tyrosine or forms a very little tyrosine. So what happens is, if the diet contains phenylalanine, it starts getting accumulated in the body, which can be fatal if too much, toxic and fatal. And there is not much tyrosine for dopamine formation, so we have to provide through diet this tyrosine. So, so knowing beforehand what the genetics are, we can tell parents of babies or something that please avoid phenylalanine containing foods. And nowadays babies are screened for this. Cluster persistence is a classic case of nutrigenetics. People with normally everybody grows out of, and lactase is non-functional in adults, but if somebody has this SNP, then basically their lactase is continuing to be functional in there, and they can digest milk without any GI disturbances and all. And you see that there are so many different ethnic populations, which actually have different types of SNPs, which help them keep the lactase like functional. So other cases are salivary amylase activity, where some people living in like some regions of Europe can metabolize starch very easily, whereas people living in Arctic regions and all cannot do it because they don't have enough salivary amylase. Similarly, G6PD deficiency is another classic case of it, where those who have this mutation in this enzyme can and eat fava beans can actually develop hemolytic anemia, and it can be fatal. So how do the complex diseases work? Complex diseases are the one where you have multiple genes, multiple environments, like obesity is one of them. What do? The people do it many times and then validate it again and again and again. Single genes are hard to find, but once they find, we know the solution faster. But complex diseases where we have multiple genes and multiple environment, like in obesity, we have diet, physical activity, social environment, so many things are there. So it's difficult. So classic case of one, I want to mention methylene tetrahydrofolate reductase, which converts homocysteine to methionine. That activity is slowed down if it has this SNP. C has been converted to T, this position. So what happens is there's increased homocysteine, it increases blood pressure, increases heart disease risk. So we need to give dietitians, they have to give them more folate so that they can overcome that. Caffeine, I'm sure you have heard of people who say that, oh, I drink coffee at 3 o'clock, I can't fall asleep in the night. And some people say, oh, I can drink coffee at 10 o'clock and I can still fall asleep. Basically, slow metabolize. If they have the SNP, caffeine tends to stay in their system for a longer time and does not get metabolized fast. So obesity, a little bit, Dr. Ashraf already talked about it, so I won't go in detail, but we know there are several environmental factors which affect obesity. Even in genetics, we have so many genes which have been shown to affect obesity. So some of them have been replicated again and again, like FDO, fat mass and obesity related gene, and BDNF, brain-derived neurotrophic factor, and there are many, TMEM18. So they all have been shown to affect obesity in many, many studies. But still, we cannot find still a solution, because the problem is that each ethnic group has a different frequency of, or how many people have that is totally different between ethnic groups. So we have to have ethnic specific studies to go anywhere nearby. So how do we apply this to obesity? So there are some studies or nutritional genomics. So there is this study which is done by Dr. Davis et al. And what we do is we find out if this is a study on sugar sweetened beverage intake. So they looked at hepatic fat fraction in children who were taking SSB. So they found out that this SNP in this gene, phospholipase, it breaks down fat in liver. So this SNP, they found out that children who had CC genotype, one C coming from one parent, the other coming from the other sin. Okay, so they found that they have 10% of their calories from sugar intake or 40%, it didn't really matter. In the second one, similarly something. But if they had GG genotype, they should rather limit themselves to be less than 10%, which is what is recommended. So similarly here, this another study, which was done for BMI, if you see that if those who had TT, sugar sweetened beverage consumers had higher BMI, and this one also higher BMI. But if they have AA phenotype, the genotype, then their BMI is much higher than others. So basically, genotype provides a ground where environment can act, basically. So what is precision nutrition? So basically, what we are doing precision nutrition is an approach to understand human variability. How are people different in each community? No one size fits all. Dr. Ashraf also talked about it, but no one size fits all. So how can we tailor a customized intervention program to improve health or reduce obesity? So precision nutrition goes beyond nutrigenomics. It's not just genomics or epigenomics. It also includes microbiome, which is also metagenomics, and metabolome, and social determinants of health, which is such an important role. So if you see this picture in one of my papers, it didn't come out really well, but you have to consider a lot of these factors: physical activity, psychosocial determinants, and other microbiome, and all these factors. And then we look at how the difference in energy intake and energy expenditure. It's not simple equation that, oh, energy taken, energy expenditure, and gone. No, there are so many other factors affecting obesity, and also individuality is so important because everybody responds differently. So this is another picture or which talks about genetic sequencing, how we can come up with, like, it's like a summary picture where genetic sequencing, first we do genetic sequencing, we know what genetics a person has, then also circadian rhythms, which I didn't talk about much, but it makes a difference at what time they eat, how much time gap between the meals, and cultural background. We have to, so important, and we have to incorporate with daily habits. Otherwise, we'll never be able to do a proper intervention. And then behavioral and socioeconomic status, physical activity, and metabolomics. This is all the phenotypes, basically. And then gut microbiome. Now it is catching up so much, like how our microbiota can affect how people respond to diet and can reduce body weight or decrease BMI or body fat percentage, and eventually lower the rates of obesity. So I'll stop with this summary and thank my team for helping me, and thank you and happy holidays.
Can you hear me? Can you all hear me and see the slides?
Yes.
Okay, perfect. All right, I'll just make this brief so that we will have more time to listen to Deepu as well. The objectives would be to see whether there's a role for Endo-Bariatrics, which is endoscopic management of obesity. What are the options available, and about this partnership between the surgeon and the endoscopist who is doing bariatric surgery, bariatric procedures. So as we have heard already, this is a big epidemic, and we also know that the treatment is inadequate with 95% of patients getting inadequate treatment. So we definitely need better treatment options and better access to care. Most of the gastroenterologists manage this because they see a lot of patients who come in with metabolic MAFL, which is a new name of NAFL, which is metabolic dysfunction associated fatty liver disease, or MASH, which is metabolic dysfunction associated steatohepatitis. So the relevance, just as a brief introduction, is about 30% of patients who have MAFL can progress to MASH, or previously known as NASH, in about 6 years. And more importantly, about 10 to 30% of NASH or MASH can progress to cirrhosis, and about 5% of MAFL can progress to HCC, or hepatocellular carcinoma, which is predicted that obesity and NASH and MASH are going to be the leading causes for liver transplantation in another 20 years. So the management of obesity obviously has a comprehensive approach. It needs collaboration between all these team members, and we are listening to all of them today, or at least most of them today, including the endoscopist, the surgeon, starting with the endocrine obesity medicine physician, dietitian, behavioral coach, psychologist, and so on. Obviously, it is a teamwork. And various medications. There are bariatric surgeries available for patients who need about 30 to 40% weight loss. And endoscopic bariatric therapies are usually useful in patients who need about 15 to 20% weight loss. And we know that the medications that are currently available are rapidly getting more and more effective, and soon I will lose my job. The toolbox. What is in the toolbox for endoscopic treatment? So there are various gastric therapies and small bowel therapies. And the treatment can essentially be seen as either it's a malabsorptive treatment or it is a restricted treatment. So some way you are able to reduce the size of the stomach, or you're able to cause malabsorption of nutrients from the small bowel. So that's a broad division of the treatment modalities. So we have all heard of gastric balloons, different types of gastric balloons, plication procedures inside the stomach, which the commonest thing is the endoscopic sleeve gastroplasty, commonly known as ESG. Aspiration therapy, which is, again, I'll come to that in a second, transpyloric shuttle. Small bowel therapies like bypass mimics, intestinal bypass with magnets, and duodenal mucosal resurfacing. Tailored approach has to be done essentially based on the patient's phenotype and also the BMI, and in addition to every other factor that has been addressed by the previous speakers. So this is what the gastric balloons appear like. The different types of balloons, which may be single balloon or double balloons, which are normally inserted into the stomach endoscopically, and you fill it with fluid or with a gas, inert gas. Most of these balloons stay in the stomach for 6 to 12 months, and you have to remove them after 6 to 12 months. The benefit, it does give about 10% total body weight loss, whereas the excess body weight loss could be in the order of 30 to 50% excess weight loss. Relatively safe procedures. The serious adverse events rate is only around 1%. And it does help with the metabolic function and improves the metabolic status of the patients who are focusing on that. The second treatment that's available is the aspire therapy, which is a modified or a glorified version of a PEG tube or a feeding tube. It is a reverse PEG tube. You place a wide bore catheter into the stomach from the skin. And essentially the patient is, after the food, lets out about 30% of the calories out into the toilet. So sounds a little bit ridiculous, but it's very well sought after, because it does give about 50% weight loss. And the main benefit is you can hold on to this for as long as needed. You don't need to take it out, unlike the gastric balloons, which have to be removed after 6 to 12 months. So it is effective, as you can see here. The side effects with the benefits with the aspiration therapy or the aspire therapy is about 20% total body weight loss can be achieved, compared to Roux-en-Y gastric bypass, which could be 30 or 40%, which Deepu will talk about. and reasonably safe, just as safe as a PEG tube placement for feeding. So the one that is more popular these days is the endoscopic sleeve gastroplasty, or the ESG. I had a video, I don't know whether it will play. Obviously, it's not playing. So essentially, you have an endoscopic suturing device, which is used to plicate the stomach. You put about 10 to 12 sutures, and you reduce the volume of the stomach endoscopically by about 70 to 80%. The procedure takes about an hour to hour and a half at the most, and patients most of the time they go home the same day. It is effective, and you can see here that the total body weight loss can be 13 to 20%, 13 to 20%, with excess body weight loss up to 50%, 50. Adverse events are, of course, it will happen with any procedure, but adverse events are less compared to a surgical procedure. Obviously, the risk, we had to always weigh the risks and benefits. The major complications that have been reported have been extra gastric hemorrhage. Like when you're suturing endoscopically, you could accidentally grab an organ which is outside the stomach, and you could cause damage to that organ, or which might need surgery to be fixed. But very, very rare, extremely rare. So we do this as an outpatient procedure, and patients are sent home. The only drawback is this is not completely covered by insurance, although it is changing because we are getting a CPT code very soon. So ESG, or that sleeve gastroplasty, can also be done in patients who have had a gastric balloon previously and who failed gastric balloon. And you do the sleeve gastroplasty, and you see the volume of the stomach has gone down significantly. The 5-year ESG follow-up, which again shows that the benefit of the ESG actually persists. The maintenance of the weight loss does happen with ESG, and it's reasonably cost-effective compared to the other medical and surgical options. The other endoscopic bariatric options are transpyloric shuttle, or the Baranova, which is still in a trial stage. Gastroduodenojejunal bypass liner. So you're putting a sleeve all the way from the stomach all the way to the proximal jejunum. So basically, this is a malabsorptive phenomenon, malabsorptive device, where it mimics the Roux-en-Y gastric bypass anatomy because nothing gets absorbed. Food goes straight through the tube all the way to the deeper parts of the jejunum. So you bypass the stomach and the small bowel, proximal small bowel. So up to 54% excess weight loss has been reported in 12 months. Again, not available in the US. Some basic physiology at this time. So we know that insulin resistance syndrome is mostly caused because of too much of anti-incretins. And this is related to duodenal lining overgrowth, or duodenal mucosal hyperplasia, which causes duodenal hormone hyperactivity, which leads to insulin resistance. So this theory has led to this treatment option, which is called duodenal mucosal resurfacing, which has been very recently approved by FDA. And essentially, you put a device all the way into the duodenum, and you inject saline into the mucosa and burn the surface, causing hydrothermal ablation and ablation of the hyperplastic mucosa, followed by regrowth of normal mucosa. It's supposed to restore the normal hormonal status and help with weight loss. So more than weight loss, this treatment has been found to be effective for management of diabetes. I'm sure Nisha will probably talk about this as well. Again, this is another treatment that is still in trial stage. The magnetic anastomosis, or GI Ventos, it's not available in the US for sure. So essentially, you go in with an endoscope through the mouth, all the way deep into the small bowel, and leave one ring of magnet here on the upper proximal small bowel. Then do a colonoscopy, go all the way to the small bowel through the ileum, and then leave another ring further down. So when you leave some time, these two magnets will be allowed to come close together, and you can bring them into a position using fluoroscopic guidance. And when you leave it for long enough, the magnets will cause tissue necrosis because of ischemia, and essentially cause a partial jejunal diversion. So a sort of a bypass situation. So how can myself and Deepu work together? yes, of course, we have to work together because he's our president. In addition to that, on a more serious note, so the management of weight loss has to be a collaboration between the bariatric surgeon and the endoscopist. And my bariatric surgeon at my university, at my hospital currently, is the one who I work with all the time. So we have a very good relationship, because any patient who fails endoscopy treatment, I escalate it to bariatric surgery. And any patient who I do not believe will benefit from endoscopic treatment. For example, if somebody comes with a BMI of 45 and asks for endoscopy treatment, obviously that is not the right treatment for him. So I would obviously divert them straight away to a bariatric surgeon. And there are other ways we can help with the bariatric surgery as well. So some patients we saw that a lot of patients are not actually going for bariatric surgery. These might be the several reasons why patients may not opt for surgery. I'm sure Deepu will be able to say why, how we can actually allay all those fears. Endoscopy is also useful for management of post-bariatric surgery complications, which are very few. It's needed in about 30% of patients post-bariatric surgery, repeating a surgery for management of a complication from bariatric surgery obviously increases the morbidity and mortality. So you always try to minimize the invasiveness of the procedure needed to fix the complications if needed. Anastomotic strictures from surgeries, hemorrhages from surgeries, band erosions, all of them can often be managed endoscopically. Bariatric leaks related to bariatric surgery and even weight regain after bariatric surgery can be managed endoscopically as a first option, first line. And obviously, if it fails, then you go back to Deepu. So I'll skip this slide. These are other mechanisms by which we can actually help the surgeon by using septal occluders that is used by the cardiologist. We can use the same device to close defects. We can use stents, and we can even do an endoscopic myotomy to reduce the pressure within the stomach. Endoscopies also help with a management of gastric fistulas, which can happen as a complication of gastric bypass sometimes. And the endoscopy suturing has about 95% success for management of this condition. Once you have gastric bypass, if you can still form stones in your bile duct, your anatomy is altered. So previously you would always need a surgery assistant or intraoperative ERCP to clear the bile duct if they form stones and the stones get deposited in the bile duct. Nowadays, you are able to do it endoscopically completely, using endoscopic ultrasound to form a gastrostomy and use that access to remove the stones, which is called EDGE procedure. And ESG, as I described before, can be used as to salvage patients after post-sleeve gastrectomy if they gain weight again. You can consider that if the patient refuses to go for gastric bypass. This just shows that the patients have excess weight loss with ESG is about sleeve gastroplasty, about 17% total body weight loss. Whereas with laparoscopic sleeve, it's obviously much more, 23% total body weight loss or more.
Feel free to use 1 more minute.
Okay. So this is a gastric bypass. This is a outlet of the stomach. And when the outlet of the stomach or the gastrojejunal anastomosis gets dilated, they start noticing weight gain. And this is another situation where you can endoscopically manage it by suturing this gastric outlet, which is called TORE procedure, TORE, transoral outlet reduction surgery. To summarize, obesity affects about 40% of the population, as you've heard. We do need a multidisciplinary team for management of all this. And manipulation of the gut offers the best total body weight loss. Further research is needed. And just to speak on behalf of Endo-Bariatrics, it is less invasive compared to a big surgery. It is reversible, you can repeat it, and it is a low cost, and the patients often are able to go home the same day. Up to you, Deepu. I'm pretty certain that I'm able to convince you that endoscopic bariatrics will be able to replace bariatric surgery.
It's a hard task after Ben. So on the foresight, I can tell you that, we do work a lot with endoscopists, and especially interventional endoscopists, all the things which he had talked about. So I'm just going to focus very much on the techniques of surgery. Obviously, the merits of the surgery has been discussed in nauseam, and we all know bariatric surgery keeps a place at 30% or more weight loss. So we see 100 to 120 to 150 to 180 weight loss. So that's where it is in right now in the spectrum. So going into, this is my credentials, no disclosures, basic things, obesity, BMI, you can see the morbid obesity, severely obese, the range. This is important because that's where the surgery comes into when 35 to 35 and above. So you can see here how obesity, this is a dated slide, but still kind of, this is worse now, but you can see how obesity is more towards the southeast of the United States, and it's not that, it has grown to northeast, and it is now spreading to the western side of United States as well. So indications of bariatric surgery, NIH consensus, more than 40 BMI or 100 pounds or more overweight, and BMI between 35 to 40 with 1 or 2. It's not just 2, 1 or 2 significant comorbid conditions like diabetes, hypertension, sleep apnea, hyperlipidemia, and so forth. And obviously, we have to prove that they have gone through medical weight management and other options, and they have exhausted those. So in this slide kind of shows where it's actually a slide which kind of shows that bariatric surgery starts off as a cost higher, but starts leveling off. And whereas other treatments, actually, the medical management keeps on increasing the cost. So in about 3.5 years, the bariatric surgery pays for itself. This is one of the prime drivers for almost all the insurances to cover bariatric surgery at a point with the NIH criteria. So this is a very significant slide. Most of you have to kind of take a look at it. And here I'm talking about resolution, not getting better. You can see with bariatric surgery, type 2 diabetes get 95% resolution, hypertension 92%, sleep apnea 75%, and so forth. You can see the only thing we talk about here as improvement is cardiac functions. So this is primarily the reason many of the people go for bariatric surgery. It's not about, hey, I want to look good. I mean, I always ask why, I do the interview what Dr. Ashraf was talking about. Ask them, what is your goal? And I have not come across one single patient come and say, I want to look good. First and foremost, they say, I want to be healthy. I want to play around with my grandkids. I want to start walking better. I want to do a lot of things which other people take it for granted. Simple things like crossing their legs. You will not know how happy they will be when they come back after a year to kind of say they have achieved their non-scale victories. So there are some exclusion criteria with high substance abuse and untreated major psychiatric diseases. Some patients are extremely high risk patients. One of it is can be considered as about 600 pounds. We usually bring them down to 500 pounds and improve their cardiovascular risk and then get the surgery done. These are patients you cannot even imagine how big they are. We do tell that when you're trying to lose weight, it's very hard to maintain 2 lives. And that is why we particularly tell them not to get pregnant within 18 months, but some of them do get because actually fertility gets better with bariatric surgery. Surgical options, I'm going to talk mainly about, there are many things we can talk about, but I want to focus on 2 things. One is sleeve gastrectomy, the other one is Roux-en-Y gastric bypass. And I'm going to go into detail of each of it. So Roux-en-Y gastric bypass was first done in 1967 and laparoscopically done in 1992, over 70% excess body weight in 2 years follow-up, and about 50% excess body weight in 14 years. That kind of shows the sustainability of Roux-en-Y gastric bypass weight loss. I'm going to play a video. Hopefully I can do better than Ben here. Are you guys able to see? I think.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. The upper portion of the small intestine is reconnected to the lower part of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. As with all weight loss procedures, behavior modification and dietary compliance plays a critical part in determining the long-term success of the procedure.
All right. So what are the advantages of gastric bypass? It has the greatest impact on comorbidities like diabetes, particularly, and then relatively rapid weight loss initially, but at around 1 year, bypass and sleeve kind of gets into the same weight loss. And there is also showing, it also shows a greater sustained weight loss. And some people seem to believe that dumping syndrome is an advantage because it kind of prevents you from taking high sugary food items. That means when the small bowel is not set to take high sugary food items. So when the food is bypassed into the small intestine very quickly, then if there is any high sugar, then you'll feel some cramping, diarrhea, feeling of jitteriness and stuff like that, which kind of prevents patients from taking high sugar meal. So disadvantages, it is technically a little more intense procedure than sleeve gastrectomy, slightly higher operative risk, and some people say its disadvantage is dumping, and you can obviously understand why. And it can also cause marginal ulcers if you're a smoker or you restart smoking, and if you take NSAIDs, and which include aspirin. And we are we always fight with the cardiologist that, hey, you can take 81 milligrams of aspirin. So I said no. A small dose of aspirin can also cause marginal ulcers. And then the most dreaded internal hernias, which is when you separate the bowel and reanastomose, you cut the omentum tube, and so the mesentery too. And when we reanastomose the mesentery, sometimes there could be some openings which can come up after you lose weight, because small openings can become large after you lose fat inside the bowel. So inside the belly. So that bowel can go into those hernias very dreaded, and it has to be done. We have to be quickly diagnosed. So going to sleeve gastrectomy, it's again a restrictive procedure. 80 to 90% of the stomach is removed, and also granule cells are removed. So that means the hunger is, at least in the initial first year, you don't feel that much hungry at all. Some people even have to put alarm clocks to eat and drink. So that's with main advantages of sleeve gastrectomy. And I have a video of sleeve gastrectomy too. I'm going to play it faster so that we don't waste time.
The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is mixed with digestive enzymes to help break down the food to a more simple form, so that it can be more easily digested and absorbed when it is in the small bowel. During the sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. The bile and pancreatic fluid from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments needed for the sleeve gastrectomy. As with all weight loss procedures.
So with gastric bypass and sleeve, it increases the gastric transit. That means the food goes into the small bowel very quickly, and thereby increasing the food goes into the TI, terminal ileum, faster, and so it increases the GLP production. So it is naturally one of the mechanisms by which the bariatric surgery works is by increasing the GLPs innately. So sleeve gastrectomy advantages are weight loss almost comparable with gastric bypass. Obviously, it doesn't have any anastomosis, no marginal ulcers, worry that much, but still you can have some ulcers if you still use long-term NSAIDs. No internal hernias because we are not touching the small bowel, and hence we are not dissecting the or separating the mesentery. And disadvantages are, it has only long-term data about 20 years. I mean, if you can think of it as a disadvantage, but there is a lot of literature about sleeve gastrectomy, which is very effective. Very rarely, one or two insurances may say sleeve gastrectomy is not covered. And the other major disadvantage people have seen is production of reflux diseases. So some people, when they try to eat large quantities into a small stomach, and obviously you can see it can only go up, then go down. So the reflux is worse, or development of a hiatal hernia or missed hiatal hernia can cause refluxes. So patients with Barrett's esophagus, there is no literature as such saying that data saying that they shouldn't do it, but most of the bariatric surgeons do not do sleeve gastrectomy with Barrett's esophagus in fear of that it can get worsened with sleeve gastrectomy. So surgical complications, obviously all this in the left side you see is for surgery, and the right side is mostly for bariatric surgeries like ulcers, anastomotic and staple line leaks, anastomotic strictures, GRD, anemia, and nutritional deficiency. So what I tell my patients is that if you look at the context, you are as safe as flying in an airplane or better. So bariatric surgery has come to a stage that it is very safe to do. I can show you data that we do sleeve gastrectomy within 22 minutes and bypass within an hour and a half. And even with the highest risk pair patients, we can get them out of the table very quickly. And post-operatively, most of the patients go home the very next day. So, and we are doing more and more robotic these days. So robotic surgery has helped decrease of pain a whole lot. There are many patients who even say that they don't even believe that they had the surgery because they didn't have any pain post-operatively. So that is changing the picture a whole lot these days, to say a few. But there are side effects sometimes for patients who get nausea, vomiting, fatigue, flatulence, belching, food intolerances, acute hair loss. As with most of the doctors here who is treating weight loss, they have probably noticed that weight loss can physiologically bring hair loss. So we treat them with biotin and other micronutrients and make sure they don't have any deficiencies. So many times people ask, what procedure? How do you choose this? How do you choose that? All these things we consider when we decide on which surgery to be done. And usually I'm going to quickly go through this roadmap to bariatric surgery.
Yeah,
to give
30 seconds more, please.
Well, I'm going to consultation, some preoperative testings. We do mandatory support groups, dietitian, and diet supervisions, and then go to surgery. We obviously talk about 2 to 4 ounces drinking, and pretty much it's a combined effort of all these things to have the bariatric surgery work well. So that's pretty much it.
So no disclosure. So we're going to discuss the digital health and AI advances in obesity management. Yes, I will be showing some apps. So mostly this is some pictures because it's on digital health, not much text. No disclosures. And one of the main concerns as physicians treating South Asian patients is the risk of cardiovascular mortality. And let me remind you that the South Asian BMI cutoff is much lower than the Caucasian population. So always we have to keep that in mind. Our BMI definition for obesity is 27 and for overweight is 25. So BMI more than 25 with a comorbidity has to be considered very seriously in terms of cardiovascular risk reduction. So this is the stepped approach. Dr. Ambika Ashraf nicely outlined the pharmacotherapy aspect of it. So I want to concentrate more about lifestyle modification. Yes, it is achievable. We can all lose 5% of body weight by changing the diet, improving our lifestyle. But then the sustainability is what we all struggle with. So we've been advocating for diet and lifestyle for 25, 30 years. The obesity epidemic is spreading globally. So the main problem is the behavioral change and adaptation that we can sustain. This is the pyramid again. As I outlined, the self-management of obesity requires scientific guidelines and consistent interventions. The hope is that with advanced, more consumer-friendly digital health tools, we can sustain the adaptation of behavioral changes. With medication, it is possible, but then we are often bombarded with questions about, do I have to be taking these medications lifelong? What happens? So I'm seeing my Ozempic patients 3 years, 4 years down the line. What do I do with them? Are they going to take the medication forever? Maybe a subset of patients will, but then we need a multi-pronged approach so that they can come off of the medication and maintain the weight that they have lost. This is where the challenge begins. So this is the market. So obviously everybody's interested in this market these days, especially for people who are interested in stock market. Maybe you can give me some insights as to where I should be investing. But then patients are also bombarded with products. The market is almost going to be 1,000 billion in US dollars by 2032. Global digital health market, predominantly based on diabetes and wellness apps, obesity, etc. Patients are as confused as us, but then they're often navigating this complex landscape. They look forward to us in giving them some tips. So it's better that we are also empowered with these tools. These are some of the big players. Teladoc, Fitness Keeper, Fitbit, and Noom are very popular among patients these days. And their social media-based interventions also, interestingly, have been found very successful. You'll probably see a lot of influencers on Instagram, and they have successful stories or anecdotes to tell us. But then how long do people sustain these interventions following a ketogenic diet or any other form of diet? A lot of South Asians are into intermittent fasting these days, but then the sustainability becomes the question again. These interventions do help, and social media plays a big role in positive influence. Even at workplace, there is enhanced adoption of these digital health tools being offered to patients as part of overall employee wellness. Now, there is increasing availability of AI-based applications in obesity care. We have applications aimed at research and clinical practice. Of course, there are potential benefits and challenges that come with it. AI-driven digital therapeutics are becoming popular. So gamification is one concept that is increasingly getting accepted. And then there is availability of AI-powered cognitive behavioral therapy and augmented and virtual reality applications. Supposing, a patient walks into your office and you want to teach them about a particular diet, and then you have virtual reality applications that you can offer to them in your office so that they can understand why they should choose one food over the other. They can visualize the benefits, and they can actually real-time visualize the change or potential benefits they're going to see by changing a certain diet. It speaks, as we say, a picture is worth more than 1,000 words. And these are some of the apps, but of course we'll be sharing the slides. And there are deep learning and machine learning models being used in obesity studies. And we are also interested in predicting obesity related outcomes. So Benjamin just mentioned that, in MAFLD, fatty liver disease, only 30% will progress to cirrhosis, 5% will develop hepatocellular carcinoma. So how do we identify that person? Maybe, from a liver perspective, only that percentage of people need to be treated aggressively. So that is when the AI-based algorithm is going to give us more analytic tools to predict. So the predictive models are going to be helpful. And then, of course, AI-based statistics and big data, we are already using these tools. And AI is also being used at diagnosis and risk assessments. Most of us South Asians have higher cardiovascular risk. We need more powerful AI-based tools to predict the outcome, maybe at the pre-diabetes stage, not at the diabetes stage when everybody's on a statin. So I'm seeing a patient with pre-diabetes and maybe borderline cholesterol. How do I know that this patient is going to need a statin? The current algorithms are often underestimating the risk, especially in South Asian population. So that is where we are going to see applications of AI as powerful predictive model tools. So AI is being used in remote monitoring. Some of the tools we are already using, we are all using telemedicine. We are all using remote monitoring, but maybe it's getting mainstream in your telemedicine clinics. Remote monitoring tools are getting very advanced. I use it for monitoring my patients' diabetes data. So I see their data from my virtual telemedicine platform, so I can track their glucose readings real time and even the insulin pump settings. And then that way I can optimize the treatment. Some of the tools are already being used. Telemedicine, I use it for remote monitoring and treatment of patients, especially in this province. Northern Ontarian people are underserved, so I still see a lot of patients up north. If even from a clinical perspective, so there is improved adherence to certain kind of medication. If you're following them closely, more clinical interactions are meaningful. Otherwise, the compliance is bad, and there is less stigma. Patients are logging in to see you from their home. So often obesity patients are afraid of going to the clinic because they feel, even waiting in a reception area is traumatic to them because they feel that they are being judged. So there's less stigma through telemedicine. But then the potential barrier is physician inertia. There is a recent survey showing that only 1/3 of physicians find telemedicine more convenient. Maybe we have this inherent bias against certain types of advancements, especially technology enabled. We are always suspicious. And mobile apps, chatbots, and as I mentioned, social media itself is a powerful tool to do health advocacy and awareness. And wearable devices are increasingly popular. So some of us are actually describing more digital health tools and apps than medications these days. So, and there is a new powerful AI, because there is often challenge that when I'm seeing my patients remotely, how do I get their blood pressure and vital signs? This is going to be a game changer. Some of these facial recognition technology tools are getting more advanced. You will be able to understand the oxygen saturation, respiratory, not just vitals, blood pressure, not just the common vitals, but you'll be able to even see their stress and even predict atrial fibrillation. Atrial fibrillation tools are already available, but then there are some face recognition tools going to be made available to us soon, such invaluable tools. And then this is a prescription app, which is used as a multimodal digital health application. Again, this is a commercial vendor, and this is from Germany. It is getting popularized everywhere. And there is a recent Cochrane data showing that, of course, we have all these powerful tools, but again, even with the existing apps, we are finding that the sustainability of digital health apps or digital-based intervention is not that encouraging. We have literally hundreds of thousands of apps, if not more, available, but we are not seeing sustained success with these apps still. And mobile health, these apps, we don't have to be skeptical. Most of the good apps are monitored and have gone through regulatory guidelines, so we can safely use these, provided you are using a validated tool. These are some of the organizations working across the globe supporting our digital health tools. And these are some of the newer devices. Omron has a new Vital Insight monitor, again, helps to remotely monitor their blood pressure. And then there's another one. This one has no, you don't have to recharge it. It has, of course, recharging, and you get discouraged by charging your Fitbit and Apple Watch and all that. So many devices to charge every day. So there are other battery-powered tools coming out. A lot of innovations happening. And again, the future of home health monitoring. If you go to any major conference, you see some digital health booths these days, powered by Alexa. Some of these tools, you can just ask your Alexa, what is my blood pressure? What is my blood sugar? So it'll tell you based on what device you are wearing. These are all powerful tools again. And there are fitness trackers. These are the good ones, more advanced ones. There are more out there. And if you don't like to wear a watch, there is a ring that you can try. I think it's $300 or $400, tracks your sleep activity. These are really good tools that you can advocate for patients to buy a good Christmas gift or holiday gift that they can ask their family members. Cost is, of course, a concern. Aura is a ring, and that is also a very well-validated tool. And then we have sleep trackers. Yesterday at the AKMG Canada meeting, we had a nice session by Dr. Rajan Thomas and Dr. Shabir and Dr. Krishna Kumar on sleep medicine. Very well received session. And how do we slack? You don't need to go for a sleep study, but then there are trackers that are getting validated for day-to-day use, or we can use them from our home. So these are two good trackers that I found online, and Fitbit has a good one called Fitbit Iconic, easy to track. And then mental health, again, yesterday Dr. Shabir was outlining how mental health coaching is effective for sleep and metabolic diseases. So these are some of the validated tools. There are hundreds of thousands of mental health apps available free of cost. And the Noom is a very popular app in obesity medicine. So it kind of understands the behavioral challenges and advocates for changes. It's not just a calorie counting app. It has more features added. So, for anxiety, mindfulness is also a big element of obesity medicine and coaching. So Noom is very popular, and there are some research studies about his efficacy as well. Again, another interesting aspect is that when the GLP treatment became popular, now all these app companies want to capitalize on the GLP market as well. So they are offering Noom as an add-on. I mean, it is partly true also. You can't just give a prescription to a patient, okay, start Ozempic and you come back and see me in a year. That is not the real world approach or evidence-based approach. You have to help them develop a habit of following digital, lifestyle changes. So these companion apps do have a place. So Noom, for example, is helping them, choose what to eat. And sometimes their protein intake is less when they are on Ozempic. They lose a lot of muscle mass. So Noom kind of guides them through that. So they need the support. And it is seen that GLP plus Noom based intervention is translated to better weight loss outcomes. So they may get, because sometimes they have gastric side effects. So these apps will help them navigate through side effects and stress and all that. So they are supportive and cumulative in that sense. So Noom is also offering some, I don't have any investment in their stock, but I haven't used it, but I know friends who are using it. A lot of my patients use it too. And they're offering support for muscle mass sarcopenia management, even cost navigation, especially in the US. So, that way this approach, and you can get more benefits out of the treatment. Social media, of course, powerful tool for data sharing. You can share your success story. Patients are doing that. One of my patients run a big diabetes advocacy group on Facebook. She has thousands of followers. So it's a patient advocacy group. They discuss what you tell them. They criticize. So good, interesting social media data sharing, communication, and then peer grouping. We do that too for our own AKMG activities. So they have been found to be very successful in reducing weight, BMI. And again, sustainability is the problem. People lose interest after a while. And then there are smart scales. You can actually measure the body composition from your home, and there are food scanning apps that actually tell you, if you're at a restaurant and you're struggling to find out, there are food scanning apps that will tell you the calorie, and not only that, gluten. You can detect the amount if it has gluten in 5 minutes. And there are smart cutlery that are available as tools. They will tell you to chew slowly, or these are mindfulness techniques that can be practiced using these devices. And then after meal analytics, etc. And another important aspect or interesting aspect, especially for teenagers and young adults, gamification is being used as a therapy because they get gratification and points and reward system. That is also catching up, and it's very popular among our youngsters and our children who are struggling to lose weight. And another gamification aspect is also coming. It is becoming popular in the ADHD world. So ADHD is also a cause for weight gain. And sometimes with ADHD, you're not able to adapt to a certain lifestyle. So you're binge eating or you have eating disorders and other cognitive problems. So such apps are useful in the ADHD world, again, translated into benefits. And so gamification of healthy eating and diet control. Microbiome test, again, we are getting more AI-based analytics based on microbiome tests. This can be done at home, easily done. Lab tests that can be done at home, like your COVID test, you can do all, even HbA1c can be done at home easily. And again, these are some of the apps I just outlined. We're going to see more effective tools based on AI, whether it's apps or precision medicine. So I have a slide, and this is the body composition AI. I think I'm going to invest in the scale soon. The company has approached me. There is a Canadian manufacturer. Also, this is an AI-enabled precision diagnostic tool.
30 seconds more, please.
And some of these are widely used globally also, body composition, AI-enabled scales, powerful tools when you're using Ozempic, and we're always worried about sarcopenia. So these are services that we can offer. And precision medicine, we just saw the genetic influence on weight and weight management. So this is one service that we are offering. This is a Toronto-based startup called Nutrigenomics. So this is actually the kitifican. Oh, you don't see my slides. So it's a saliva-based genetic testing. We can understand some aspect, but again, I often struggle to explain the results to the patient. It's not, is it correlation versus causation? And generative AI is also a powerful tool. We probably see better chatbots as coaches online, and they can also do tailored treatment plan advice to our patients. Thank you.